growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everybody, Dr. Steve Rasner here, welcoming you to another episode of The Lionhearted for those clinicians who refuse to quit. Those of us that aspire to that fee-for-service practice we once dreamed of in dental school, or when you first opened up, and maybe you aren't there yet, but I'm here to help you to get there. It's a Monday night. I got snowed out today partly, so that's the kind of stuff that happens to all of us sometimes, right? You're going along and having a great month of January and even February. And you wake up in the morning on a Monday and there's a whopping half an inch of snow out and everybody cancels. I always say I'd be better off if it really just snowed a foot, because if it snows an inch, I'm dead. Anyway, thank you all for the continual responses you've been giving me and my Dr. Rasner at AOL. You're going to want to write that down again tonight, because there's probably some things you're going to want me to send to you. So be sure to write to me and let's get going. Tonight, I want to talk about communication. And I'm going to call this What to Say When. It's really, really a lot more important than you think. Don't turn the podcast off yet. I'm telling you, just give me the first opening couple minutes, and I'm pretty sure it's going to resonate with some of you. Because how we say things and what we say so much determine the outcome of whatever it is you're talking about. So a lot of you know I wrote a book about 10 years ago called The Protocol Book, What to Do When. And the first thing I'm going to tell you tonight, and you may want to write to me and have me just send this to you, and I'll have Beth Hoffman send it to you. It's 2 protocols out of that book. And the first one's called, and it's really simple, but I'm going to tell you, these things have a lot to do with minimizing the bumps in your day. And man, you need to minimize the bumps in your day, because after 365 days in a given year, you're going to have some bumps. Because even when everything goes great, it can be tough sometimes in the course of the year doing what we do. And that's why I'm here, to help some of you save a lot of years and save a lot of time from one clinician who a lot of people think has a pretty decent practice. So here's what I want to start with. You may want me to mail these to you. These are 10 things that we don't want our front desk employees to ever say. Here's what they are. I can't. I don't handle that. I can't find any record of that. Even if you can find a record of it, don't say that. Sorry, we're closed. You shouldn't even need me to say that to you. I haven't had time, blank, blank, blank. Oh my God. And by the way, remember, my protocol book was written by things we actually did in my practice. So every one of these things I'm telling you, I don't handle that. I can't find a record of it. Sorry, we're closed. I haven't had time. Every one of those I heard in my office. Number 6, what seems to be the problem? Oh man, you really want to start a problem with somebody that calls it as a problem? Or has maybe like a little attitude? I'll have to ask the office manager, what is this in reference to? She's not in today, and it's our policy. Let me tell you something, man. You're not even allowed to say that in my office. It's not our policy. That is the biggest turnoff that any business or company could say to me. So I definitely don't want you reiterating those type of words. She's not in today, so you may say, it's easy for me to say. Yeah, it is easy for me to say, because I offered a resolution in my office to every one of these that needs a resolution. They all don't need one. Just don't say I can't. That's it. And I mean this, by the way. This isn't an optional thing. Let me tell you, man, the road can be hard sometimes, even when you do everything right. You know, I can think, and it's nothing to do with what we're talking about right now, but I know it'll resonate with many of you. I'm thinking of a patient right now, a family of 4 that came to me faithfully for 20 years. Husband and wife, 2 kids. Every 6 months. And guess what, by the way? They never needed anything. He had this outrageously unaesthetic front central incisor crown done years before me. The headlight crown, you know, the crown that comes into the room a few minutes before he gets there. And I would bring it up once in a while, but it was very clear to me. Actually, it wasn't clear that it was about money. It was just clear that he was comfortable with that tooth to me. By the way, it had a history of root canal and crown. It was probably done every bit of 20 years prior. And by the way, at this time, it was probably like the year 2000. So we're talking about a crown probably done in the 70s, maybe early 80s. And so I never really brought it up. 20 years into coming to me, this family of 4 that never broke an appointment, that crown's off, and it's broken. It's at the gingival margin, which is no shocker, and I recommend an implant. And I don't remember the details at that time, but what I do remember is that he would have to reach into his pocket for the first time to make a considerable copay in addition to his insurance. Remember, this is 18 years ago. And back then, very few insurance companies covered anything on an implant, including the crown, which many of them do today. And he left me. Family of 4. And we got along. We had no prior. So I'm just saying to you, one of the, I hope, takeaways from these podcasts is that I live in your world. I'm a 64-year-old practicing dentist for 38 and a half years, 39 in September. Yeah, I've spoken and lectured for the last 20, 21 years, but man, I get it. You know, it knocks me off my feet sometimes. And it's just what we do, because we're in the people business. And I guess there's a lot of you out there that it doesn't bother you. But after practicing for approaching 39 years, it still bothers me when I lose a patient. It bothers me, just me being honest. It bothers me when I don't make a patient happy, even if they don't leave me. I probably err on the side of I do too much to make the patients happy. But you got to be who you are. You got to be comfortable in your own skin. Anyway, the reason I'm saying all this is because you don't need problems to be created by your own staff because you don't have protocols in place. So my staff can't say it. Sorry, we're closed. I can't remember somebody ever coming in like we're a bank and we had to extend hours like that. But I'm talking about a phone call. And we can handle most phone calls that would put us in an unusual situation. But I will tell you that sorry, we're closed are just words that aren't going to happen in my office. I can't find any record of that. It's just a useless statement on any level. I just wouldn't say that. I'll have to ask the office manager, or she's not in today. Both go along the lines of you have to cross-train members of your team. In fact, I used to lecture early on and say cross-training was the way to enlarge your staff without enlarging your staff. And it's like all this stuff, I get it. All this is hard. It's nothing easy until it's done, and then it's just part of the way you operate. It's part of the way you exist. So for me to sit here and tell you that you should cross-train your team members, I understand that requires some energy and work and could take you 6 months or a year to get all the people on the same page, to get the team up to the level that it'll make a difference. So let me give you an example. If I had an office of 4 or 5, I wouldn't have just one person that could do insurance. I would at least have some cross-trained individuals that could step in if that were necessary to get answers, or looking up a bill. Did the insurance come in? Just basic parameters. Another cross-training example, even though that's not what this podcast is about. It'd be nice if I stayed on track for more than 5 minutes. I hear me. I know what I'm like. I used to make sure the front desk team members could just basic chairside assist if need be. I'm talking about suctioning. I'm talking about helping evacuate a patient with you. And this really means a lot more when you have small team numbers to operate with. So, things like that. The proper way to answer the phone. I mean, you may have I'm a strong believer that the phone should be answered on the second ring, regardless of how big or small your office is. I really don't go for the answering machine that says, sorry, we're dedicated to the patient that we're working on right now. And I know some of you listening very well do that. And if that works for you, then do it. I used to have a slide that said everything counts when I was explaining the success that I've had in my practice over the 38 years. And I believe everything I'm telling you helps for the long-term enduring success I've had, including answering the phone on 2 rings, including not saying any of the things I just said not to say. One more thing before I get back to communication. It is the second, it's another protocol in this book that I'm reading to you, which I want to do if I get time on some of the podcasts. So then, for number 1, you won't have to buy it. And number 2, they're pretty interesting. I even know I wrote them. I wrote these a long time ago, and most of them are very, very relevant. So this one's called I Know We Goofed. So tell me, this is what this one is. It's when you have a situation like I had last week, by the way, where you just goofed, man. End of story. There's no way around it. The lab case wasn't there, and you numbed them. Or you numbed them, and the shade was off the 3rd time. By the way, real quick protocol, and I have a lot of protocols. Never numb the patient on an anterior case until you at least hold it up and you tell them that. And make sure you're in the ballpark worth numbing them, because I realize once it's on the abutment, once it's inside the lips, the teeth shades and contours look different. I get it. I've been doing this a long time. But, my protocol wasn't that for years. We just would go in and numb them and say, I'm sorry, but I'm not even talking about that. I am talking about you closed early. I had a patient today. I swear this is truth. And it snowed here as I opened my podcast with. And so we moved all the patients from 9 to 12 just to save a lot of lateness from patients. I did it for the patients. I could have been there at 9. I walk in my reception room at 10 something, and there's a patient in there. And some of my team's not there yet. And I go to my front desk. I said, who's that sitting in the reception room? Of course I didn't know, because that's one of the things I always insist that we know. Check in as a patient comes in so we don't leave people waiting. And at this point, I don't know, it was about 20 after 10. He was waiting for his 10 o'clock hygiene because he didn't get a phone call, even though I was told everybody was called. And so he'll fit into the category. This is called I Know We Goofed protocol. So here's what I did for years. I had pre-made up gift baskets. They cost me about $15 to $25. It depended how bad the mistake was. Okay? You know, maybe you tried a crown in and you didn't like the distal margin on the radiograph and it was open and this patient wasn't so forgiving. They weren't that patient. I know what I'm talking about here. They weren't that patient that was forgiving because they know you aspire to such high levels of excellence. They were a driver patient, a driver personality that all they know is they're coming back one more time for one tooth. And you should have got it right the first time. That's what I'm talking about. And you just walk in and you keep it simple. You say something like, sorry, I know that was a tough visit. I'll be better next time. I guess I'm telling you, I don't even like the word sorry, quite frankly, because it kind of puts you in a defense, which I know you need to be. Just own it. Whatever the problem is, just admit it and own it. Like, wow, I know you don't like going through this impression. When you're done, say this. Or, you know, obviously you have to tell them at the time you're doing it over. Say, look, I know you didn't really want to go through that again. It doesn't happen often. I know that doesn't matter to you. You have to come back for another visit for me to insert it. I assure you it'll be right and it'll be put in this time. And maybe you hand them a small gift. Sorry for an inconvenience. This is called, I know we goofed protocol. Well, more importantly, whether you give them the gift or not, is absolutely owning it. So here's a real bad one. Last week, excuse me, last week I had a patient that we were supposed to give prophylactic antibiotics to. And somehow we gave him a sleeping pill. Second time in my 39 years that's ever happened. So, by the way, he was a new patient that wanted to stay for a cleaning. Are you kidding me? And was interested, by the way, in a mandibular overdenture. So we're talking about north of $14,000 in my office. His teeth had been extracted years ago. I mean, I'm giving you a pretty bleak situation. Imagine, I'm not kidding, full upper denture, lower implant overdenture was the treatment plan. It wasn't a full upper denture. He had 2 teeth left, which he wanted to keep. And he could keep them, by the way. So, and he hadn't been cleaned in a while, so we were going to clean them. Well, to clean 2 teeth, we inadvertently sedated him. I'm not kidding. And he came in the next day to tell me that, and he had to leave his truck. His wife had to pick him up. This guy was not a happy camper. Anyway, when I walked in the room, this is what I said. So I'm trying to teach you how to communication sometimes. You know, we don't know all these things, and I can't give you one too much worse than that I just gave you. And I walked in and said, listen, before you say a word, and by the way, I walk in, he's in my operatory chair, turned to the side, like, you know, waiting for me to come in. Waiting to attack me, I'm pretty sure. I walk in and say, listen, wait a minute. Before you say a word, let me just say one thing. If it was me, I'd be pissed too. I can't give you a reason, excuse, nothing. All I can tell you is it's regrettable. I do apologize. I've taken measures already, so it not only won't happen to you again, it'll never happen again. And that's where I'm at. Now, if you want to talk, if you don't want to talk about anything else that we discussed yesterday regarding your treatment plan, that's fine with me. I totally understand it. I'd love to have you as a patient. And if you'd like to discuss it, we would. And the long story short is I placed those implants in last week. That actually, I placed them 2 days after that conversation occurred. So let me get back to some other communication skills that I think are good for you to blueprint, to copy, because I think they're good. And these I'm going to take you into the examination because of all the all the podcasts I've done so far, the parts of the comprehensive examination seem to be downloaded the most and resonate the most of all of them so far. So I want to go back to that, and I might have mentioned some of these, and I don't know how many I'll get through, but, the first one I want to reiterate is how to say you're going to do a comprehensive exam without saying that, because you can never say that. That invokes thoughts of, this is going to take a lot of time, this is really costly, this is scary, right? So you can't walk, at any time, you can't really use the word, I'm going to do a comprehensive exam, because really no one wants to hear that. Here's what you can say. You can start out and get through all the normal things I told you to say. Where are you guys from? Be very old boy, good old boy, down home type of approach is what I would take. So after you've walked into the room and you get past, how do they hear about your office, which I always start out with, because sometimes I get information that is embracing between the two of us. Maybe I worked on their sister-in-law, and usually I have a cliff notes about that beforehand, but sometimes it's vague, and it doesn't hurt to ask that again. And then I'll say something along like this. This is what I say in my neck of the woods. I say, listen, right now you're sitting in my office. There's 20 other dentists in this area you could be seeing today. So I want to tell you what's a little different about this office. I think you're going to find this different, and I'm positive you're going to like it. And I go on to tell them a couple of things. One of the things I tell them, remember, I'm telling you how to get into explaining you're going to do a comprehensive examination. And one of the things I say is, and I'm sure if you're listening to Steve Rasner, you've either taken a lot of courses or you're in the middle of taking a lot of courses. So it's a good thing to say, listen, one of the things I think that drives this practice that you're sitting in is that I'm so into what I do. And part of that has me taking courses all the time. I mean, I've taken courses on everything you can think of connected to dentistry. I think the best thing I've learned is a concept called what to do when. Like you're sitting here in my chair right now. And how do you know what I'm going to tell you later on in this examination is the right thing? And how do even I know that? Well, I'm going to tell you how. I'm going to tell you the approach I take to examine you that invariably leads me to giving you good advice. And folks, if you say it like that, people are going to like that tenor coming out of your voice. And I go on to tell them, I'm going to look first and foremost at the health of your gums. I know that's not why you came to me, but let me tell you why I do it. And I go into the explanation of how many Americans are edentulous in one of their arches by the age of 60, how encompassing periodontal disease is on the general population, and how it is asymptomatic, how it doesn't very often in the early stages, and this is the truth. Patients don't have any symptoms when it comes to perio disease. So it's quite easy for me. It's very rarely a challenge for me to make a patient understand or convince them that they need quadrant scaling, root planing, and 3 to 4 month follow-ups, because I make it a big emphasis of how I believe in that, because I do believe that how much and how long and beautiful your work will endure has everything to do with patient compliance. And that's something you hear over and over again in your career. Trust me, it is true. You could have the most impeccable crown and bridge margins in the state of Tennessee or in the country of Morocco or the Czech Republic. It's downloaded me many times, by the way. Thank you. But I'll tell you, it'll mean nothing if you don't have a patient that comes in regularly and you don't emphasize the importance of home care. It is everything you were taught. It is incredibly important. And the clinicians in this country and abroad that have the most beautiful, enduring, lasting work are the clinicians who put a big emphasis on that. You know, we all can get excited about inheriting or getting a $10,000, $15,000, $20,000 case. I have to believe that most of us want to see it in a recall visit 10 or 15 years from now and still smile with pride. And your best shot at that is frequent recalls. Don't let anybody else, don't convince yourself that it's the patient's responsibility, although I know it is. But if you want a family of very satisfied patients years from now that invested huge money with you, you must take it upon yourself to educate them. And that's why I do that. Then I tell them this. I know that you came in because of whatever it was, but I'm going to look at all your teeth, and I'm going to tell you why. And I tell them two things. I say dentistry is different than almost any other part of the body, dental care. Because if you woke up today with the slightest of fever, a half a degree over the norm, do you really need anyone to tell you that you have a fever? You pretty certainly don't need me to tell you that. You don't feel the same. You don't feel right. Well, the mouth's entirely different. I see patients weekly that come into this office that have a periapical infection in their bone above their root apices, their teeth, and don't know that, or have a giant cavity, unless a big part of the tooth fell out. And if I can get to these problems early on in our relationship together, then it's less. Less is best is where it's at. Less time in my chair, less money you spend. That is my goal for you. And I don't know if this is resonating over the airways or those of you that can see me, but that is really how I talk. And I can talk like that because I totally know it's the truth and I believe in that. Then I talk about, remember, I'm telling them right now, I'm giving them a comprehensive exam. So what's a comprehensive exam to me? It starts with a healthy periodontium. All their teeth are within normal limits in terms of caries or old fillings that are not leaking and leading to bigger and worse problems for the patient. I mean, everybody believes that, so why not say it? Then I will say, and I change my tone a little bit, and keep in mind, I often know maybe they're there for one of these 3 reasons, and 5 reasons. Maybe it's the rare patient that calls and says, my gums bleed, and I know I need periodontal therapy. Or, I mean, how many patients come into you and say that? How many patients come in and say, look, I have a toothache on the upper right, but I want you to examine all my teeth? No one says that. But what I am saying right now to you does make sense to patients. Then I'll say, then we'll look at your missing teeth. And I on purpose say, and we'll see if that has anything to do with the health condition of your mouth. Now, we could be missing a lower right first molar that's been out for 20 years, where 31's drifted in a mesial angle, and it's not perfecto, but it's not going to do them in. And so it is accurate to say, we'll see if that has anything to do with the current condition of your mouth. And of course, there's many, many other times where it has everything to do with them popping restorations and having TMJ dysfunction and other things. And then my 4th subject is that. I'll say we're also going to look at what dentists call your occlusion. You call it your bite. And your muscles around it that are involved in that. And if any of that is not as healthy as it could be. And then the last thing I say, and I do this on purpose, and you can disagree with me, but I'm just telling you it's what I do. I say, and the last thing I'll look at is your aesthetics. How you look to you. How you feel when you look in the mirror or see yourself in pictures. And that's a really up to you thing. If you're okay with it, I'm okay with it. So that's really how I get into. And I want to tell you, I really am appreciative that this message is getting out to many of you. It seems like my podcast, well, not seems like, they're definitely growing. Each time I release one, there's more and more downloads. And I appreciate your time is what I'm trying to say. And so I'm trying to keep them relatively condensed. I have a lot of other ideas. I have many other communication things. I'm going to make a part 2 to this about what you say to the patient that comes in that's never had quality comprehensive care. And we all know what I'm talking about. Some of you bought practices like that. And it's a very fine line for you to walk. How do you break that into the patient? I'll talk about the good old Joe doctors without throwing them under the bus. I'll talk about how to take advantage of those of you that have worked more than even 5 or 6 years and how to use that to your advantage. I'll tell you the power of looking at a patient who needs you to say this is you say, I'll tell you exactly what I would do and why. There's a lot of, I call these raps sometimes when I lecture, but for now I'm just telling you I'm going to call them what to do when. Some of you have requested some topics, which I really want you to keep coming with that, please. Say, I'd love you to talk about this. Some of you want me to put on Michelle, who's been my financial coordinator and my new patient coordinator for only 38 years. And she's very lovely at communication herself. And she'd be good to know how to get people to come out of network. How do you comfortably talk to people about paying up front? And lots of things I've alluded to in other podcasts. So I have a lot more to say, and I'll keep doing these as long as I feel I'm resonating. And that's a word I haven't used too much tonight, right? For goodness sakes. I appreciate you listening, and I'll see you next week on The Lionhearted.